Good afternoon, everybody. My name is Samir Vora. I am a general pediatrician and the founding chair of the Department of Population Science and Policy at Southern Illinois University School of Medicine. On behalf of our department, the SIU School of Medicine Center for Rural Health and Social Service Development, the SIU Paul Simon Public Policy Institute, and the University of Illinois at Chicago School of Public Health, I want to welcome you to our latest webinar in the Rural Health Summit series, COVID-19 and Building a Rural Health Workforce. We have an incredible panel for you today and a very special guest moderator. But before we get into the full discussion with our panelists, I want to remind everybody of how we got here. And this is the sixth in a series of webinars where we have tried to understand and address the challenges around COVID-19. For those of you that have been frequent participants in our webinar, you know that we've talked about an aging population, mental health, public health systems, nutrition and fitness, children's growth and development, and today we'll be talking about the very important and meaningful topic of a rural health workforce. To get here, this planning committee convened stakeholders in late 2020 and early 2021 for 11 discussion forums to better understand and address the COVID-19 pandemic in rural Illinois. We were fortunate to learn from 80 leaders from 55 different organizations in fields such as public health, healthcare, academia, industry, philanthropy, government, and community leaders who met virtually to discuss how the pandemic is creating new challenges, but also fostering innovation in ways to build on those challenges to create brighter futures for our residents all across rural Illinois. We convened after those discussion forums an interactive session where we synthesized solutions and thought through how the information, anecdotes, and issues raised could really create a list of policy recommendations to build that more functional and better addressed rural Illinois. So as mentioned, this is our sixth report. And for those that have not seen the other reports, wanted to mention them for you and also plug to visit the Rural Health Summit website where you can see all these policy briefs in more detail. We started in March 2021 around building a healthier rural Illinois, understanding and addressing the challenges of COVID-19. That was our summary and synthesis document, really sort of mapping a strategy across all sectors to understand and address the challenges posed by the pandemic. In April, we thought through how we could think about ways to improve the health and lives of our aging rural population. In May 2021, we discussed the challenges around our mental health systems and how the pandemic really stressed those unique entities, causing increased challenges around mental health in our rural communities. In July, we tackled the big problem of our public health systems strapped because of COVID-19 and how we could build on those moving forward. In August, we talked about rural nutrition and fitness, the challenges around food insecurity, and how we could build better options for better nutrition and fitness for our rural communities. Last month, as school started, we talked about children's growth and development and the many challenges posed to our children, their families, and their communities around education, learning, and ultimately their healthcare access. And today, now for rural health workforce. And as we get to this important topic, we thought it was really important to have a leader all across our state, Ms. Goody Kapadia from the University of Illinois at Chicago School of Public Health, be our guest moderator. Ms. Kapadia has been working in public health workforce and education and development for over 15 years at the UIC School of Public Health. She has led multiple training projects, including the Centers for Disease Control and Prevention, Illinois Public Health Preparedness Center, and the Illinois Preparedness and Emergency Response Learning Center. Ms. Kapadia was part of the team that worked with the Cook County Department of Public Health with the CDC-funded Communities Putting Prevention to Work grant, an initiative designed to change policies and environments so that healthy eating and active living is the norm for Cook County residents. So I'll pass it on to, and very thankful to Ms. Kapadia for being our guest moderator for this important discussion on building a rural health workforce.
Thank you. And I believe I get the great honor to introduce our panelists and for today. These are colleagues that I have worked with and look forward to working with into the future. So thank you first and foremost for volunteering your time today. First, we have Amy Fox, who is the administrator at Tazewell County Health Department. Ms. Fox has worked in public health for over 31 years in the areas of community health improvement, planning, health promotion, substance abuse prevention, coalition development, and emergency preparedness. Currently, in addition to the responsibilities in Tazewell County, Ms. Fox is the co-chair of the Public Health Committee of the Illinois Terrorism Task Force and has worked as an advisory team member with the Methodist College on a HRSA nurse education practice quality and retention grant opportunity, expanding opportunities for nurses to develop the understanding of public health practice, policy, and community assessment. Next, we have Dr. Hannah Hinkle, who has held leadership positions in both public health and academic medicine. Prior to joining the University of Illinois College of Medicine, she served as the Director of Community Health Personal Services for a rural health department in Northern Illinois, and currently serves as the Interim Director and Department Head of the National Center for Rural Health Professions at the University of Illinois College of Medicine, Rockford. Dr. Hinkle is also the president of the Illinois Public Health Association, where I get to be the secretary with her, and is involved in a number of state and national groups. She's an expert in healthcare systems delivery, recruiting and retaining a strong healthcare workforce, addressing rural health disparities, culturally appropriate healthcare and public health interventions, implementation and evaluation. We have also Dr. Jim J.D. Daniels, who is a board-certified family medicine and preventive who's board certified in family medicine and preventive medicine. He's worked at the medical school, SIU's medical school, for almost 3 decades in various roles, including the residency program director, fellowship director, vice chair, and assistant dean. He was awarded a fellowship through STFM, which I hope you'll tell me what that means later, to study the rural healthcare provider crisis in America, and was the main architect of SIU's new Lincoln Scholars Program. This project developed specialized training for all healthcare providers to not just work, but to thrive in rural and remote areas in Illinois. And finally, we have Letitia Bo-Prighton. She is currently the president of the Illinois Community Health Workers Association. As president, is responsible for sustaining and growing the first community health workers association for Illinois. The goal of this is to unite community health workers, community health worker groups, and stakeholders and allies to create one voice and advocate for policies around CHW interests. Her experience includes working with diverse and at-risk populations, connecting them to resources and services in and around Chicago, managing food pantries that have served over 1,500 people monthly, asthma education, diabetes, empowerment education, peer educator, and more. She was also awarded the Community Health Worker of the Year Leadership Award by Senator Richard Durbin. So before we get started into more of what we've learned, I wanted to share, just as you've seen from the report, as fewer medical graduates choose to go into primary care, there's been a clear shortage in rural America, and especially in Illinois and Southern Illinois. In Illinois, all non-metro counties have a shortage of mental health professionals, nursing, public health, healthcare, and we continue to see this as being an issue. Rural residents in Illinois have long faced significant health provider shortages, and as a result, often wait longer for provider visits or forgo medical, mental health, or dental health care altogether. and this pandemic has exacerbated the challenges of attracting and retaining rural health talent. So, as the pandemic increases the reduction of services, the instances of stress, burnout, and death of the workforce has also made this a huge impact. Rural areas have long suffered from a shortage of healthcare and public health professionals. I asked the panel, what challenges did rural regions face pre-pandemic, and what sort of issues are being exacerbated by the pandemic? I would love to hear your responses with the healthcare audiences that you work with, so medical students and residents, nursing, public health practitioners, and community health workers. I'll let you decide who wants to go first.
I can jump in first here, Goody. Thank you for the introduction and the introduction to this topic today. So we know, as you've mentioned, these challenges in healthcare workforce, especially in rural populations and underserved populations, it's nothing new. They're incredibly persistent. From my perspective, and looking at the academic medicine side, recruiting rural medical education students to practice in these very vulnerable communities, we've seen this over time as well from the recruitment angle. So getting, academically prepared rural background students to come into the health professions, and for our purpose, for the RMed program, to track into rural medicine has been a challenge, but I feel like we've, addressed some of those gaps and education deficits and sort of experiential deficits by having pipeline programs in existence. And we've been lucky enough to have funding from HRSA through the Area Health Education Network program to do that. But in the long term during COVID, we're also seeing not only the recruitment issue, but also the retention issue. So all these issues are layered on top of challenges with, addressing maybe vaccine mandates among healthcare workers that may or may not be supported among the workforce. And, considering some of the incentives that are pulling people away from working in rural communities, like doing travel nursing, for example. There's huge, sign-on bonuses now. So how do we compete as, a healthcare infrastructure against some of those temporary incentives to pull people away to areas of other need? And so now we're trying to focus on the full spectrum through the College of Medicine, which is a recruitment piece, and now retention as well. How do we keep people in practice once they're there through the pandemic?
This is Amy. I can jump in next. I think pre-pandemic for public health, as we become more ingrained in our community and it's really embracing that chief health strategist role, we have some specialty positions that we're wanting to bring on to public health. They're very hard to find, epidemiologists being one. So it's very, not only attracting someone to a rural area, but finding enough people in the discipline who can be available to you. We've had to do nationwide searches to find epidemiologists to come here. Also with staff like nurses and dietitians, we have had to really make sure that we get good relationships together with our community colleges, that we really make sure that we are being good stewards and having students come and do rotations at public health so they can even understand what we do. I think there, when you think nurse, a lot of times we think OB or emergency room or ICU, but what does public health nursing, what is that? What does that do? So really working with those programs, I think, is work we were doing really intentionally pre-pandemic, and hope to get back to that.
It's Letitia. I'll go. So we ended up hosting some webinars and Zooms for our community health worker workforce at the, when the city started to shut down, the state started to shut down. And what we learned through those webinars was that the biggest theme for community health workers was that they were not being acknowledged as essential. So a lot of community health workers lost their jobs. Some of them, most employers struggled with, just trying to figure out what their priority was going to be based on COVID. So a lot of the CHWs were, jobs were minimized to just, minor tasks. But the resilience and the compassion of community health workers definitely had them to reach out to some of their clients themselves, but a lot of the community health workers had to support each other because a lot of them did not understand what was going on. So I think learning about, the COVID was important. Finding out from them, how do we support them regarding their work, their lack of employment was another big thing. And then finding avenues to give them factual information around the COVID was important. I'll stop right there because although we're based in Chicago, we did, open this up to the state of Illinois because that is who we are, trying to unify the voice of community health workers across the state. So we definitely understood the access to health, the access to factual information where people could understand it at their level was challenging. So all the more reason for us to help our community health workers and promoters to get as much information as they could so that they can better educate themselves, their families, and their communities.
Thank you.
Doesn't leave me. Yeah, that well said. I guess as far as my background is probably central and southern Illinois, between like Springfield, west central Illinois, and southern Illinois. So I know that area fairly well. And what I think what happened with the COVID is that there was, if you look at health care as a big iceberg, COVID was a bunch of salt that was dumped in the sea, and it made the iceberg raise. And what it did was it showed a lot of people that there were a lot of issues that were under the surface for a long time, and they came to the surface, and it kind of caused a crisis. And we kind of could learn a lot. That symbol for danger in the Chinese language is also opportunity. And there's a lot of things that we put a lot of resources in that we can maybe use them more wisely. From a public health standpoint, we try to come out and be informational and be transparent, but when you get to a point where it's large populations, it kind of granulates into other skills that some of us don't have, which are public speaking, ways to sort of win people's hearts, not just their brains. And that's where we're starting to shift right now, is that pretty much every person out on the street kind of knows a lot about COVID, but the problem is that it's all different. And there's a lack of trust, so sort of everyone does what they can. So things have become a little more global, in a lot of ways more tribal. And so, part of it is deciding new ways that we can use the resources which we have, which I think are a lot. And as far as with the rural health, I think there's a lot of stuff there, but the big issue that I sort of see is that the pipeline isn't a pipeline. What it is a bunch of pipes that are laying in a ditch. They're not connected. So, we've spent a lot of time on how we're going to get someone to rural health, rural areas, but maybe not a whole lot of time in the rural areas talking to folks saying, well, what is it? And the big thing is what keeps folks there. If you say, we're going to give you a scholarship for, we're going to pay your medical bills off, and then in about 4 or 5 years, you haven't bonded with community and you leave. Or our primary care residencies all across the country have been sort of emptied. And so the group of folks that we're spending a lot of time and effort on in medical school from our state aren't really staying here. They may go someplace else to train. And then we know from statistics, if they train in another place, it kind of cuts off their ability to kind of come back because things happen. So, we have to kind of look at that. And when we look at, as far as like being a residency director, there's lots of pressure, lots of different things to do. But what we kind of want is to make sure that we have the best residents there. And many times, if you look at the names of the folks and where they came from in the residencies, compared it to the people that we train in Illinois, they don't match. So we have a lot of folks that are from maybe another state or even maybe another country, and they're the ones that actually stay in the community. So there has to be kind of some thought to that on what we're doing, and also our ability to kind of bond together. What gives me great hope are the folks that I've been working with and been around. These students that are coming through the whole pipeline here, they've got a lot of cool stuff. They look at things a lot different than us old boomers here. And they work together well, and they've learned to kind of group together. And I think that might be one of the things that'll help us a lot and also make things fun. And I'll stop there.
Thank you, Dr. Daniels. You actually are setting me up for to talk about, so one of the first policy recommendations that has come out of this work group and these efforts is talking about providing incentives and opportunities to maximize, to recruit and retain rural health workforce. So if you don't mind continuing, you know, as residency director, what are the biggest reasons why residents don't want to join rural residency programs? And then how are you making those residencies more appealing? And we will get through all of these other policy recommendations throughout as well.
Okay, here we go. Here's the story. I don't think a residency record can do it by themselves. I think we have to sort of work together on what we're doing. What happens is that there's a culture that starts to form. So when you're in medical school, what everybody kind of wants to do is we don't really study health, we study disease. And so to get this disease, what you have to do is you have to be in a large enough population to see the disease. So when you train there, it's almost like you're training out in the Atlantic Ocean, and you learn how to like live in the Atlantic Ocean, but then you're going to move in to a pond. So the same kind of things that you did and how you looked at life have to change. Example, everybody talks about distribution and all this kind of stuff. There are more physicians up in Chicago than there are in Springfield. But if you look at the numerator and the denominator, excuse me, the density is highest, one of the highest actually in a lot of places in central Illinois, right in Sangamon County. So that's where we train most of our students. And if you go there and you swing a dead cat, you'll hit 4 doctors. So the way that you treat is much different in primary care. It ends up that you're really more of a management, in a way, sort of a sophisticated medical social worker. And I don't want to say that being flip or anything, but basically what it is directing folks through the system, because there are so many doctors and actually so much resource that part of your job is to help people kind of go through it and not actually be kind of abused by the resource, and to use the resource wisely. When you go into an area where there's a smaller population, your job is much different. You basically can't say, I'm not really sure what to do, so I'm going to like send you down the hall. You have to be able to sort of take care of this. So what happens is that everybody has a capacity of their brain. You can carry so much. And we train sort of this way, kind of vertically. And really in rural health, what you have to do is you have to turn it sideways. And you have to kind of go across. And that's why this integration of different folks working makes much more sense. And it keeps people happy, and it keeps people from burning out. Hope that answers some of it.
It does, and I think, Dr. Hinkle, you touched on this as well, but your institution, the National Center for Rural Health Professions, works closely with the BH Well program, and that focuses on placing more social work students into rural communities. So, can you talk a little bit more about how the social work students and the medical students are working together, and that need of working across much more?
Yeah, absolutely, Goody. Happy to do that. And Dr. Daniel set that up perfectly in terms of, why interprofessional education training is so important, and, how that lends itself to more successful outcomes for rural populations down the road. I would like to just fill in a detail for our students who train in the RMED program, that, our secret sauce to this is really getting students from a rural background, and we evaluate them sort of on how rural they actually are in their upbringing, and then also how their level of social accountability is, how strong that is going into the program beforehand. And so our program outcomes have kind of demonstrated that we're a little bit of an outlier, which we're happy to be in this context, where our students, regardless of where they go to residency, they end up going back to practice in a rural community similar to where they're from. And again, I think that really lends itself back to the background of that student profile, even before they get into medical school or our program. And with that program, we actually create these training opportunities with the Be Well Scholars, which is a HRSA funded program. It's a fantastic program that does incentivize economically a little bit social work students to go and train into rural areas. But at the end of the day, that also creates really nice networking opportunities for these students to really understand, you know, the classroom is beyond the walls of their campus. It's really the communities that they're going to be practicing in one day. And the opportunity that we have working with Be Well Scholars and the RMed students sites are really fantastic in the sense that these students, when they train interprofessionally, they understand early on in their training the roles and responsibilities, the skill set, the sort of, you know, qualities and characteristics of each discipline that they'll be actually tasked to work with in the future, you know, in terms of a team-based care setting. So that's really been a tremendous success for us to be able to bring these disciplines together. We also work with rural pharmacy students, rural nursing students as well at a DNP level. So they're actually, you know, mostly nurses in practice that come back and work with these undergraduate medical students and social work students, and, you know, can share and learn their experiences. And so I think it's really just a tremendous model that we have here where you can demonstrate, you know, all of the assets that each discipline brings to the table early on, where it's sort of low stakes in their training. And then once they graduate, they're all set to go and can understand, you know, the public health system, the social work aspects. And that really leads to better economics in healthcare as well. When physicians and social workers understand each other's roles, they can better, you know, identify issues early on for their patients, adapting a public health model, which can improve quality outcomes for the entire system. So that's something that we're really mindful of in our training opportunities we provide.
Thank you. And Dr. Hinkle, you're setting me up for our next policy, you know, recommendation, which is that, again, and I think this has been touched on with much of what's already been said, is that we need to build real community health workforce collaborations between public health and healthcare to enhance service delivery. Again, it sounds, you know, what you have been saying and what Dr. Daniels was saying, that it can't be done alone, right? And so actually, I'm going to look to you, Ms. Fox. How can local public health departments leverage their connections outside of healthcare to help build stronger rural health workforce?
Well, I think it is just that. I think it is that collaboration and partnership, that building of those relationships prior to needing those relationships, you know, so that we can understand each other and work well together. You know, I think everything from insurance to the healthcare provider to community services to support services in the community, churches, food pantries, all of the things that supports a family and a healthy life have to kind of be brought to the table. And I think that uniquely public health tends to be a good convener of that. I do think that we have had some experience with that through local public health planning, through our community health needs assessments and our community health improvement planning. We have been bringing healthcare providers and other support services to the table to look at gaps in our community and what our needs are, and having real discussions about those and how we might impact those. And I think those have been building blocks, honestly, to leverage. I think without relationships, I'll give you a quick example. When COVID vaccinations started rolling out, we were getting very, very few doses. And so we were sitting down as 3 county health departments and 4 hospital systems each week on Wednesday night when we would find out the doses, and literally take off all of our logos and hats and say, like, what's the best use of these doses and how can we get them out to people and work as a unit to get our community vaccinated as quickly as possible, starting with our healthcare workers. And I think without having built those relationships and understanding of each other prior to when COVID hit, I don't know that we would have been as successful as quickly. So I do think it is that relationship building and that convening of the questions that will help to foster those non-traditional partners with healthcare and public health.
Thank you. Which takes me to Letitia. as we talk about these non-traditional partners, as we talk about bringing other players to the table, how can we encourage higher community health worker recruitment in the rural areas to play some of these connecting roles? And what are key challenges that these individuals are facing specifically and how can we reduce them?
Thank you. I am really enjoying the panelist discussion, and I love this talk about the Ms. Hannah, you talked about it, but this collaborative educational piece where everybody is learning and working together. And I think I was in this conversation some years back. People are unaware, most people are unaware of community health workers, who they are, the value that they bring to any system that they are a part of. So continuing to educate folk and uplift the role of community health workers is very important. So I like SIU, they've been training community health workers, the Illinois Public Health Association, we've worked with them on training community health workers. So the more we get people talking about community health workers, the better. And the more that is talked about in those training settings where our doctors, our social workers, our nurses are being trained, the better. Because that team approach, as you all are talking about, is so important. And in a rural setting where, transportation is hardly there, a lot of resources that people can get to is just really it's not so easily accessible. It's important for community health workers to kind of jump in that mix because they can because of their unique ability to relate to the communities that they serve, look like the communities that they serve, they can work with our providers, our doctors, our social workers to kind of be that extension to kind of help get people into the resources that's needed or be that listening ear to figure out what is also needed. So we definitely support those types of effort. And then I also think about, we start from the community level, right? And so I think in a lot of situations, community health workers are not even aware of the advancement, the career advancement that can happen. And so I think to the retention piece that Dr. Daniels was talking about, engaging more community health workers, discussing a career pathway will kind of help, in that aspect of getting the community folk to stay in their area because they're already there. Even within my own story, like I was a community health worker doing asthma and diabetes education. My career pathway took me to social work. It was a natural fit for me, right? And so, but it wasn't until I started talking to folk and even my advisors at school to let them know I have a passion to help people. That's like my jam right there, And so them linking me to the career pathway of a social worker because I really didn't want to go to the medical, like doctor, nurse. Like I wasn't interested in that. But learning more about social workers and what they do is just like a natural fit for me. So I think the more we talk about it, the better. And just to kind of touch on policy for community health workers, we are slow to the table in Illinois, but we're getting there to recognize the workforce, CHW important to our workforce, which helps because in the past, under the Quinn administration, we did get some legislation going, but now in the Pritzker legislation, along administration, along with the historical healthcare pillar bill through the Legislative Black Caucus, we're able to take the recognition of community health workers a step further by establishing a certification process and a payment structure through HFS, our Medicaid. So this, in addition, is something that helps the workforce because now there are ways, for further recognition and also sustainable financing for the workforce in Illinois. So I can go on all day, Goody. You know me. I'm going to stop right here because we don't have a lot of time.
No, thank you. And I just want to acknowledge that there are questions coming from the participants, and we will get to them. So please continue to share additional questions, and we'll get them to the panelists. But I do want to touch on our last policy recommendation, which is augmenting telehealth infrastructure and capacity in rural areas to improve access to medical and behavioral health specialists. So as Letitia brought up, access points because of distance, because of the scarcity, et cetera. How can we increase that through the advances of, exactly what we're doing today through these virtual platforms and the like? So Dr. Daniels, how is the young generation of physicians being trained to leverage tools such as telemedicine to bridge the capacity gap between urban and rural practices?
Well, don't ask old guys like me. Those young folks can do more technology than any of us. You don't have to really train them. They come up and do it themselves. So that's really not an issue. The issue is, how do you use this? So I'm going to back up just 1 second and kind of go, because Letitia, I've already fallen in love with you. You need to come down and see us in Southern Illinois here, give some talking. But the deal is, I want to give a shout out to this place down in Southern Illinois in Saline County. It's called Egyptian Health Center, and what they've done without anyone really telling them, and to me, it's an advanced model, low budget, populations dispersed, no money. So what's happened is the hospital and the school system and the public health have merged. So when you go in, you will walk into their school, which the whole county goes to. Connected to it is almost like a hospital. It essentially has all the healthcare right there. And what that does is it allows not only people to get healthcare, what it does is what we've been talking about organically. Those kids see the dentist, they see the nurse, they see the doctor, they see all those people in their building that day. So they don't only get to be treated by them, they get to interact. And at that age, they're more like stem cells than differentiated. So it may be someone who says, look, I'm the captain of the football team and I want to be a doctor. Then you go and look and go, that ain't what I want. Or you might see someone who comes in, they're kind of shy and they don't have a whole lot of stuff, and they go, well, I want to be a doctor, or I want to be a social worker, whatever. So I think that's how you retain things. When you get the students themselves that are sort of not as far down the pipeline, they seem to me in a lot of ways have clear vision, and the other younger folks kind of go to those. So that all sort of fits in with all that. As far as the telemedicine stuff, I think that it's sort of growing, and I think it has some good parts. I think it has some bugs. And so what I'm going to do is I want to tell you an example and see what you think. I want you to go back to rural Illinois 20 years ago, before Walmart and McDonald's were there. And when you would go into those different towns, they were very cool, and they had businesses that served that community, and those businesses did very, very, very well. That is what I call right now our rural access hospitals. They're the heroes. They're there on the boots on the ground doing their job. Then what happened was Walmart and McDonald's came in. Let's get forward now and see what happens. Your choice has gone down, and it's the same thing all along. So I'm not cutting down large medical establishments like SIU and U of I and the big conglomerates and that, Barnes and that, but we have to be careful that our own interests don't sort of bleed over to where we're saying what we really think the answer to this is that rural person be able to talk to that subspecialist right away. It's not going to work. What has to do is how we use that in a real way. So it may end up being that you have Letitia, who's in the neighborhood, who knows everyone, or she's in a nursing home and there's an issue, and she can actually then call either the NP or the PA or the doc and say, hey, we have an issue right here in real time. That's how I see it. But I think we have to be careful we don't embrace it too much, because a big part of medicine isn't the science. We've kind of gone overboard with the science, and we need to go back to the heart, to the art, where there's a touch. And there's a much difference, although I love talking to you folks. It would have been a lot cooler if we could have been all in the same room. I end there.
I agree. I really wish I could be in the same room as well. I know, Amy, you touched a little bit on this, on how public health is well situated to be the connecting and convening force, but how can it leverage its connections outside of healthcare, as Dr. Daniels mentioned, to help build a stronger rural workforce?
Well, I was reflecting on what he was saying about, all of the services right at the school. And when I started my career a while ago, about 20 some years ago, there was a project through the state called Project Success. And really what that was doing was bringing all of those services, community schools. So it's that same kind of model where you bring all the services together for one intent and purpose. And I think that's maybe where we really need to look at our health support system, take it in the wider view, not just healthcare, not just public health, but in that wider view of health in the fullest sense with mental health, et cetera. And look at, what is it with our one intent and purpose we want to do for our communities? And I think that, again, is kind of that strategizing, that chief health strategist kind of thinking cap that's in Public Health 3.0. And while public health has that in their wheelhouse, we're really just a convener and someone to bring the conversation to light and ask the questions. I think what you're kind of hypothesizing, that kind of rural community of years ago, could come back again. I think no matter how large our institutions are, I think we still do have that local footprint if we put our intent back to that type of service and back to that type of quality of service, I guess is what I'll be boldly say. And so public health, I think, could be a conduit. We're throughout the state of Illinois. You talked about Egyptian. I know you got your Delta network that's in Southern Illinois that's doing kind of the same kind of work. I think we're kind of all over, and so a likely partner maybe for the different systems. Certainly the universities, I think, over the years have really reached much more out into the healthcare systems and public health to try and leverage those connections. So I guess we're just always wanting to have a seat at the table and to maybe ask the questions and begin those conversations, because we do have so many different partners. When you just look at, kind of away from more what you would consider the medical side and look at our environmental health side, you have the water companies and you have the electric companies and you have the landfills and the food pantries that we're in and out of. So you kind of widen that network even farther when you think about the breadth of what public health can impact.
Thank you. I do want to take this question that just came from one of our participants. So this is open. So what would you, the panel, suggest needs to be done by rural communities at a local level to develop the interest and values in young people to return to practice in a rural community and hopefully near their hometowns?
Yeah, I love that question. So our emphasis is always grow your own. I mean, it's great to have these community academic partnerships and, have the university try to support different initiatives in the community. But at the end of the day, the success of your community relies on that community to step in and recognize, in terms of rural health workforce, the potential that a student might have in that community to be successful one day. They don't always have to be the highest academically achieving individual in that school system, but if you give them a chance, if hospitals, local health departments, so Amy, you mentioned sort of opening your doors to students and having that career exploration happen early on, and then have mechanisms from local industries or agriculture to help support, students having those different types of experiences, going to summer camps and being supported by, a local business. Those experiences matter. We had in the incoming class that we just accepted into medical school, so the class of 2025 in RMed, 30% of our students had some type of interaction with the pipeline program before they applied. And that got them interested and excited and just demonstrated the possibility that they could be successful. And they don't have to go to Chicago, or St. Louis to be successful. They can be successful in their training and then go back and make a huge impact to the communities that need them the most, the communities like where they're from. And so that investment really starts locally, and it's really about growing your own.
Thank you.
I'd echo that. I think it was well said, Hannah. I mean, I think that the community has to do, they're already doing an incredible job. And they have to do it on a number of points. And it just can't be the medical community. It has to be sort of everyone. I mean, I think that the sooner that you can get any student involved with the healthcare is best. And really, in a lot of ways, you know, I'm always on the doctor end, but really, in a lot of places, that's not the answer. Totally, it has to be this other group, and you have to encourage them. And I really think that the best thing that, if you know, a hospital I would ask is this: is that right now there is a big shortage of training slots in rural areas because this is now a buzz.
Mm.
Now money's coming. Okay.
Mm-hmm.
So what we're seeing is encroachment from other states, other places that sort of come in, and what they'll do is they'll talk to the provider directly and say, we'll even give you a stipend for doing this. And the other one say, and I can't blame them, and say, hey, look, you know, I'm doing this free. What am I getting out of it? And someone says, I'm going to pay to do that. And they don't really have any connection with the community. So the things that I would do if I was in a rural area would say, look, here's what I have. We have our town. And you might say we might kind of combine with maybe a town next door or whatever if we can't do it. But let's see what we can do to bring resources in for that upcoming group in high school, or it could even be programs, that type of thing. Because I think you almost have to plant the seed, or actually say fertilize the field before the seed, because what we've been doing is we've been throwing a lot of seed on barren ground. We've basically been forgetting about it until they're all the way through their training, and then say, okay, if you'll go to this place, we'll pay that off. Well, you know, that's okay, but just the way you do that, that's going to kind of attract a certain person. And that doesn't always match. You know, I think in a rural area, you don't have to just see that the glass is half full. You have to know where the water faucet is, because you have to be kind of resilient, and you know, there's a mental health issue. So I think that the more we can combine that, and really even at a training point, what we did with the Lincoln Scholar Program is we looked at that by comparing a lot of places across the country and the world that had really great outcomes, to be honest with you, published outcomes on people settling in the rural area. And one of it was like Thomas Jefferson in Philly. What were they doing to get inner city kids to go work and live and thrive in rural Pennsylvania? What are they doing in Minnesota? All these different things. So there's, when you put them together, they all sort of hit. And I don't want to go on forever, but all these things we've been talking about are common themes.
Yeah. No, and I want to bring back what you shared earlier, which is that we talk about the pipeline, but it's about connecting it. So I think I heard, not only introduction early, but repeated, and then, even what Letitia said, different experiences. So if you don't want to go into the pure sciences, what else exists? Because there's a large, need. And that it isn't just the medical aspect or the nursing aspect, but we need billers, we need coders, we need, we need all these roles, and we need them everywhere. So I really liked the fact that the seeds need to be planted in the right place, but these pipelines need to be connected, and they need to be as a whole.
If I may add, Rudy,
yes.
just I think us expanding on our definition of health and wellness, because a lot of times people, when they hear health, they think doctor, nurse, and some people that have something against, 12 years of education, they fall back, right? So I think, emphasizing, this broader definition of health and wellness will encompass, different social determinants of health, like your safety, your education, your, where you get your food from. All of those things contribute to a healthy and well individual. So I think also incorporating this broader definition would also kind of help. But I definitely agree with what everyone else has said about starting early, and also kind of incentivizing, our residents to go into the field and stay. So if it's like extra points given to this, Illinois rural person who applies for this, training slot or residency or program in this area, like you get extra points. And then if you stay and practice, then your student debt will be wiped out. I'm like, wishing very highly for that. Like, because student debt is a big one. So, all of those things I would just want to add.
I'm going to keep you on the spot. Then another question just came in from what formed the basis of the community health worker certification criteria and reimbursement scale? And I know you can talk about this forever, so
No, I'm going to keep it brief because I did respond to Josh, I think, asked that question. So the criteria for certification process and the requirements will be determined by the Community Health Worker Certification Review Board. But I, along with other leadership, some of our board members, have all had leadership roles nationally around the community health worker work. And so we learn from other states what's good, best practices and things of that sort. So we've been kind of paying attention to like what Texas has done, what Arizona has done, what Massachusetts has done around their community health worker programs. And we're taking bits and pieces of those things, bringing it back to our stakeholders, our membership, our board, talking to them about what will this thing look like for you. And so if you all have any interest in providing additional input in this process, I'm sure our contact information will be sent out, but you all can definitely reach out to us because we do have work groups around certification and financing, around workforce development, and we'll be having our membership committee coming on board as well. So please feel free to lend your opinion, your thoughts based on your area and your vision, because we welcome all of the input that we can get. And we'll be coming soon to, we're going to be doing some roundtable discussions. So I'll keep you all posted on that as well, because we want to get as much input as possible around this process. Goody, we can't hear you.
come on, somebody had to do the I'm on mute. I just, but there's been a question about outreaching to rural populations and meeting them where they are. As someone new to the field, I've been trying to connect and do outreach with community partners in rural Illinois, and most of what I have come across is county health departments and no real grassroots level of organizations. Are there any recommendations?
We did, I'm sorry, we had to do a training with some cancer navigators, and some of the strategies that they've shared was that they've been going to like grocery stores. They've visited and frequented places where the community is. And so I like that idea about the Egyptian project where they are like in schools and then they have a health center connected. So I think you really have to focus on where the people are. Laundromats, the dental office, and just how to be there with information at those places where they are.
I also think establishing trust is huge too when you're interacting with rural populations, and especially if you're working with communities that you're not familiar with or you're not from. It's always important to find that community champion who can help sort of guide you along, introduce you to people, interact with faith-based organizations and other community centers with that sort of trusted person, and then over time build that relationship, because these relationships take time. And as Dr. Daniels mentioned too, and Amy and Letitia, it all is about the people involved in this, and you can't sort of do it without having sort of that inroad into the community first.
We have 5 minutes left. I'm not really quite sure how this happened, and so I want to bring us back to final words around actually enabling a more sustainable workforce through policy. So how can policymakers help? What else should we be doing? Any other final words before we have to leave today?
Yeah, I would just like to comment that, obviously there's been significant impact with COVID-19 related to rural communities and, globally as well. But, at the end of the day, I think it also creates opportunities for maybe refocusing resource distribution and addressing some of these gaps that were, shown in this iceberg model, as Dr. Daniels mentioned as well. I think we're seeing more movement towards this with the Biden administration and the American Rescue Plan and the Build Back Better initiatives, which are trying to, I think, address some of these issues that came up during COVID, to rebuild rural communities, to rebuild the rural health workforce. But these are really sort of reactive approaches. And I'd like to get us back to maybe more of the proactive approach where, innovation is driving necessity, but in a way that's not necessarily in response to some crisis, And so I think if we continue to sort of educate policymakers around those evidence-based programs, the strategies that we know work to try to recruit and retain rural health, the rural health workforce, I think we're all the better for that. So we're seeing positive movements forward from this pandemic, but we still obviously have a long way to go.
Yeah, and I agree. One of the things that I think about, just two things, or number one, is that I think that when you go and you tackle, it's a big problem, but I think you have to really have it focused on the people that are there, the local folks. And so that has to be the driving force. So like Rural Health Association, or however you want to say it. And then us, like these panelists and somebody, we shouldn't be running it. We should be advising and giving them options and let them pick what's best for their community. That's number one. Number two is we're in corn country, and we set it out, but some people chop it up and put it in a silo. We got a lot of silos down here, so we're all trying to do the same thing, but there's a lot of stuff. One of the things that might get both Doc and my bosses mad, maybe they ought to bust up and maybe put SIU and U of I together in like a rural health conglomerate, instead of saying, well, you'll take part of this state and you come in this part, and if you cross over our border, it's kind of like war. So I think that would be one thing. And the other is that the junior colleges have really stepped up in the last decade or so with education. They have to be part of the answer. And really, I'd like to see them sort of drive the thing just for all the help. That's what's going to solve it, help solve it, I think.
This is Amy. I think Hannah really made me start to think about something that I haven't connected with our school partners with in many years, and that is, are they continuing to do that kind of assessment of students and what they would be interested in, and how can we support that with the school system? So I think really kind of continuing to ask questions, continuing to kind of listen to the gaps and how we might fill in. Now we've got new partners that we now know each together, and maybe we can help to build what we're envisioning. I think that's really making sure that we've said it out loud and are working towards it, I think, is one of the most important first steps.
I echo everything that has been said so far, especially this idea of letting the community lead, and, the importance of the decision makers and the people that hold the bag to kind of be in support of what the community is asking, because oftentimes they want to come in and just take over. And when that remedy doesn't work for the community, then they're sitting back like, no, they didn't want it. They didn't take this. They didn't do this. And it's because that's not what they really wanted in the first place. So as much as possible, the decision makers really allowing for more community listening sessions, more opportunities for the community to be at the table to make the decisions that they feel they need for their communities would be the best route.
I want to take this opportunity to thank all four of you. I also want to thank all four of you for all the work that I know you guys have been doing through COVID, the people that you have touched and the people that you have trained to continue to help create healthy and happy communities. Thank you to the participants. This session was recorded, and so we will be sharing that. And I will hand it back to Dr. Vora if there are any other final words.
Let me also say thank you to all of our incredible panelists. Thank you, Goody, for the excellent moderation and really sort of bringing out these really important issues and how our policy recommendations can make a difference. Just a reminder that we're continuing to do this every month. Next month, we'll tackle the incredibly complicated issue of the rural opioid epidemic here in Illinois. So we look forward to seeing all of you November 16th at 12 p.m. This will be a Tuesday. We typically go on Thursdays, and look forward to the discussion that we do and the policy recommendations to improve and really make a difference around the rural opioid epidemic. Thanks again, everybody.